Morning everyone, my name is Dawn Foster and Lisa and I are very excited to be here to open up this session with everyone this afternoon. So welcome along to today's event. It's exciting times in the world of social prescribing alongside some challenges, as I'm sure you'll all be aware. Just wanted to highlight some really recent developments for social prescribing around UCL and NASP's new data centre that has recently been announced, and also just last week the National Academy of Social Prescribing announcing a partnership with the World Health Organization. So there's lots of exciting things happening currently, and today we're hoping to take forward some of the work around CYP. So
we're going to do this a bit like Ant and Dec, so that's our plan. I'm today not Dec, I am Liza Jarvis, and Dawn and I work together. And like we say, today we're going to focus very much on children and young people and some of the developments that are happening all the time, but some of the exciting ones that we're going to discuss this afternoon. I think it's really important to say that children and young people, social prescribing, youth social prescribing isn't new, okay? We've been probably doing this for about 8 to 10 years, and so there are lots of experts in the room, and I think it's important to build on those experts. But we started looking at children and young people social prescribing probably about 8 years ago through NHS England, developing children and young people's models for social prescribing, and also working with street games to develop principles around social prescribing and how we could do this better in the community. And Dawn, you're going to talk a little bit about kind of some of those next steps with street games, aren't you?
Yeah, brilliant. So from back in the day working with Marcello Bertotti at the University of East London and publishing that very first academic paper around CYP social prescribing, through to the establishment of the Social Prescribing Youth Network, which we did while I was working with street games, and then the latest iteration of the Social Prescribing Youth Network in very safe hands with Dan and the team at UCL. We're incredibly proud of the work that's been taken forward from those early days, and we're really looking forward today to hearing about some of the new work that's been ongoing and how we're taking things forward. So I think for me, with youth social prescribing, we know, and from working with young people back up in Yorkshire where I am, that what we mean when we talk about social prescribing, for me, it's about helping young people find trusted adults and working with young people in a way that is right for them where they are at. And that might even be connecting with them when they're still sat in their bedroom and finding ways of helping them feel confident enough to start engaging out in the real world. Yeah.
And just to add on to that, I think it's really, really key to note that one of the beautiful things about social prescribing is that collaboration and partnership. It's about working together and all having a piece of the jigsaw puzzle around how we can support young people in our community, to give them choice and control and to find everyday solutions that help their health and well-being.
So I've got the all-important bit of thanking people who've made today possible, and today's event has been enabled by the UCL Faculty of Population Health Sciences, the Policy Activities Support Fund, try saying that, it's like a tongue twister, and the Higher Education Innovation Fund, so we thank those for making today possible, and also we're being supported by our valued collaborators, so the National Academy of Social Prescribing, the Southbank Centre and the Prudence Trust. So I think we're going to move on to having a look at what we've got in store this afternoon.
Okay, so you should have all seen the agenda for today, but what you'll notice is that we're going to have lots of flash talks, so lots of things around policy and practice, so everybody's going to have to be keeping to time, which hopefully we will do. But you can see here that we're going to be having lots of information, so please do make sure you're asking questions in the chat, and we're also going to have Menti, which is going to gather some information as we go, and Dawn is going to explain about Menti.
Who divvied up this talk? Okay, just a little bit of housekeeping before we get going. So you can see up here we've got people who are attending online. Please do engage with the chat functions, and also there's a Q&A section for you to put in specific questions. If you want to tag certain people, if you've got a question you want directed to a certain person or just a more open question, that would be great. If you're attending in person, the actual people in the room, you can raise your hand to contribute at any point. We are going to set up the Mentimeter very shortly. There's just 5 questions, and you should be able to answer all of the questions in your own time. So we'll pop that connection up. There's a couple of ways of accessing Menti. There will be a QR code up on the screen. There's also, if you go to menti.com, there's a code that you can type in that will get you to today's questions, and we're going to gather that as a bit of feedback from today. And oh yeah, you can please help yourself to refreshments, and the toilet's just outside and up to the right if you're in today's live session. At home, again, keep yourself comfortable, do what you need to do to make sure that today's session is enjoyable. And we're really, well, I'm really excited to hear some of the new developments that are going on from today's session. So if we can pop over to the Menti, and then we'll maybe give people a little bit of a chance just to sign in. Rachel is on the tech today. Rachel, thank you so much. So here we are. Please, everyone, just take a couple of minutes to get logged on to Menti, have a look at the questions, and we will take a little bit of feedback. I have been just asked to let you know you can go all the way through the questions. So sometimes on Menti you'll have to wait for the presenter to click through the different questions. But for today's session, what you should be able to do is go through and answer all 5 questions. The first 4, myself and Lisa, we're going to do a little bit of feedback for straight away. And then question 5, Marie Polley, who we're really happy to have with us this afternoon, is going to do a little bit of a reflective session later on, and she'll be using question 5. So if you can go through all 5 questions, I can see some people giving us some thumbs up in the session as well, which is great.
95 people voting.
95 people voting. Yeah, fantastic. It's like bingo in its eyes down at the minute. Everyone eyes down. It looks like it's working, which is the main thing. Okay, so if we can have a look at the first question on Menti. So who's joining us today? We're talking about what roles people are working in. So you'll see that the numbers keep shifting as people keep responding. Lisa, you are tag teaming this with me, so anything that you notice, shout out.
I think it's interesting that there's lots of other. I wonder what categories. Yeah, if you're in the chat, can you just put what the other is that you are? I think that'll be really interesting to see. Yeah, in the room. Is there anybody who has other in the room that wants to say where you're from?
Oh, Dan.
From Bromley by Bow Healthy Living Centre, but also have a 1-day-a-week role with the NHS London on social prescribing and social welfare legal advice.
Okay. Anybody else?
I'm National Centre for Creative Health. It didn't seem to quite fit.
Yeah, National Centre for Creative Health, so you here at home. Okay, brilliant. Rachel, what about the next one?
Or I can feed on online, but
okay. Oh wow, that's a nice spread. Across the UK. Lots of people here in London. Can we see, is there any stats other than that we can see any higher than London? Rachel, can you see? Oh yeah, up north, the 7. Okay.
Anybody?
Yeah, is there anybody internationally?
Belgium online.
Belgium online.
Hello, Belgium.
Yeah. Okay, now I start to feel like Eurovision. Yeah, absolutely. I don't recommend any singing today, especially for me. Do you want to move on to the next one?
Yeah. We also have Wisconsin, USA, and Ireland.
Oh, hello Ireland, hello USA. Wow, lots of amazing words. I'm going to hand back to you.
Okay, so the next question was, in one word, what do you want youth social prescribing to deliver? Let's have a look. Wellbeing, confidence, support. When I was thinking about this travelling down today, the words that came up for me was safety. Doing a lot of work around children and young people involved in serious violence at the minute, and safety just seems to be something that I would hope for our young people. Support, opportunity, opportunity. Some great words up here. We're going to capture this obviously, and
Empowerment is a good one.
empowerment. Yeah, we talk a lot about that, don't we? The other thing that we just talked about as well when Lisa and I were chatting yesterday was the importance of belonging for young people and not just fitting in.
Yeah.
So I think I'd put belonging up there as well.
What you can also see if you look around the edges is there's a lot of connecting words to the main, well-being, confidence, empowerment. So there's a lot of words that are connecting in there. Definitely.
Because I'm just thinking, if only we had some people from the world of academia who could, you know, theme and make sense of the information that we're being provided with. I'm just looking around the room. Who can we? I'm sure we've got quite a few people who'd be very able to do that for us. Okay, I think, is that the last one for us, Rachel, before?
Yeah.
Brilliant. Okay, so hopefully we've got a little bit of energy into the room. We've got people excited and looking forward to what it is that we're going to cover in this afternoon session. I'm looking at Dan for the nod to move on, if you're happy with everything. And we'll hand over to our first flash. I've never heard of a flash talk before the agenda got sent back. keep it presentable, Rachel. So I'm going to hand over to for our first flash talk, and it's to Rachel from the. I'm going to say the Royal Society. From the National Academy of Social Prescribing. So I'll pass this down to Rachel.
Thanks very much. Rachel, are you okay to change slides for me? Thank you. Great. So good afternoon, everyone. NASC is really delighted to be co-hosting this event, and real big thanks to UCL and the SPYN network for leading this work. So my presentation, I'm going to talk about some of the asks and the recommendations in the reports that are being published today in the light of the wider policy landscape, and I would stress it's very much a personal perspective. Next slide, please. So thinking about the policy imperative, I've just chosen 3 stats from recent government departments. There are unfortunately a lot more that look like this. We know that support systems can't keep up with demand, specialist access is constrained, and the pressure lands in schools, families, primary care and the voluntary sector. And without early support, systems become reactive, inconsistent and inequitable. Obviously, increasing financial pressures are exacerbating this situation, and there's a feedback loop. By not addressing this problem earlier, it puts greater pressure on public services and the economy, with, of course, most importantly, a growing impact on the generation's well-being. So politically and morally, there's a need to show action and results quickly within government, and I think that complex policy landscape which comes from that makes it even harder to join up across policies and funding pots, and the shift from national to local, which we're seeing across all of the sort of policies across government, can make spread and scale of good practice harder. So in the light of this, growing evidence and increased recognition that social prescribing can support the improvement of health and well-being of young people. Most recently, the excellent Future Minds roadmap, which if you haven't read it yet, I would really suggest you do, highlights the importance of social prescribers, link workers for CYP. So despite this, social prescribing for children and young people is fragmented, under-resourced and unevenly implemented. And in particular, we're not harnessing those trusted adults in schools and community settings who could take a social prescribing approach as part of their existing roles. Next slide, please. I'm just flashing this slide up. Flash Dawn. I'm going to go through it in detail at the end, but I just want to highlight that complex policy landscape where we're trying to fit an embedded and sustainable social prescribing ecosystem. I've simply listed the ones that I've been involved in conversations with in the last 5 working days, and I haven't even included things like SEND reform. Next slide, please, Rachel. So I just want to pull out some of the key asks that are in the documents, which I can take very little credit for, having not even been at the roundtables, but I know a lot of you were in the room and online, so thank you very much for your contribution to that. So how do those asks land in terms of the wider policy landscape? So leadership and cross-sector working, all of this needs strong, committed leadership at all levels. We need people who can join up the various developments in youth-related policy. I'm just thinking national neighbourhood health centres, young futures hubs, best start family hubs, social prescribing clearly needed at all of those. How can they be developed together? And in a way, that move from national to local could make it much easier to do that in place. We need leaders to champion CYP social prescribing. I'm just going to highlight that the current neighbourhood health guidance for CYP multidisciplinary teams is that they are determined locally, common phrase, but could include social prescribing, so not should include social prescribing. And we are asking for named leaders for CYP social prescribing. The number of changes nationally and locally means that there may not even be CYP teams in some of those places, let alone leads for social prescribing CYP. Support from cross-sector working is really essential, and it's leaders that can ensure that everybody is around the table, but recognising the pressure that puts on voluntary sectors, particularly smaller groups. I think we mentioned this in the best practice guidelines, but we've seen that regional and national communities of practice can be really valuable for spread and scale when taking a local approach. Invest in the workforce. This is a massive preoccupation for NASP at the moment. The Future Minds roadmap calls for dedicated CYP link workers in every primary care network, yet we're hearing about PCNs making their link workers redundant, link workers with no clinical supervision and growing caseloads, and I'll talk about the workforce plan in the next slide. Upskilling, I think a lot of us think that upskilling trusted adults in a social prescribing approach could really be a game changer. Could this be part of the £15 million has been announced for training professionals in and volunteers in the youth strategy? Wider development of the community sector is also really important, things around evaluation, fundraising, but also there's a big demand for them to be able to support young people with particular mental and physical health challenges. We're really pleased to be launching with UCL the e-learning today, and that's part of our contribution to wider workforce development. Sustainable funding, I don't need to tell anyone around the table how important that is and the impacts of insufficient funding. We are calling for 3 to 5 year funding and funding the whole ecosystem, so not just ensuring more referrals that go into poorly funded voluntary sector. And it's important to think about equity here, no wrong front door, and making sure that there's funding there for access to paid for activities. And with their role to map community assets, social prescribers have a really key role in identifying gaps in provision and also the barriers that need to be addressed for different offers. Thinking about the national landscape, there's loads of pots of money being advertised for specific places or cohorts, and the Local Covenant Fund, I think that one came out last week. The youth strategy is talking about match funding, and we're involved in conversations around neighbourhood health and pots of money there. How can we join those up? And then evaluation and metrics, I'm not going to go into a lot of detail there, but it's really important that we work together for a minimum data set, but also connecting with the development of metrics and outcomes being developed for the youth strategy, and then the data that will be collected around neighbourhood health. And if that hasn't been published, it is about to be. And I think then, most importantly, underpinning all of our asks is the need to involve the voice of young people and their caregivers. And one of the priorities of the youth strategy, I noticed, is to develop ways to do this. Can we feed in our good practice and also harness what they're developing for engaging with young people in social prescribing? Next slide, please. So, as much as I can get in before I get cut off in time, going back to, there's lots of policy and asks in our document, they're all really good ones. But what are the implications of the wider changes and developments in the policy landscape? So, mergers, reorganisations and budget cuts in DHSC, NHS England, ICB's local government reorganisation. I already mentioned we may not have those local teams and we may not have those trusted contacts that we've been developing over the years. Neighbourhood health, CYP is not a priority this time, it's frailty, but it could be in the future. There's a number of documents coming out before the end of March around neighbourhood health centres, commissioning frameworks and working with local authorities. Will we see social prescribing being mentioned in those? Some of you may have heard of the modern service framework. The detailed guidance that comes with it is quite complicated, but essentially it's just around getting the consistent delivery of high quality, evidence-based, digital by default, which is the big thing within NHS England at the moment, care, and it's going to be focused at ICBs. There won't be a new big budget for it. We've been told that there might be one for children and young people. That's a really good chance for us to influence. Even if there isn't one, older children, so 15 and upwards, are going to be included in the severe mental health modern service framework, and there's a real interest. Charlotte and I last week were talking to the team, there's a real interest in the role of social prescribing there. And these modern service frameworks have moonshots and ambitions for change, so they are potentially quite exciting opportunity to influence. The workforce plan, eagerly awaited, comes out in the spring. Will social prescribing be included? We think it's unlikely that they'll keep the targets for the numbers of staff roles at the moment. So at the moment, there's targets for social prescribers in there. There are rumours that a CYP plan might follow. Again, great opportunity for influencing. I've already mentioned the youth strategy a lot. Lots of synergies there around training, funding activities, and a focus on trusted adults and the no wrong front door, which I think we'd all agree with. It's good to see the commitment there as well for involving young people in research to explore options around social prescribing, although the language in that is quite unusual. So I think my takeaway from that is we shouldn't necessarily see all of these initiatives and various reviews as a challenge. They're also opportunities and hooks to promote social prescribing and the specific asks and ideas that we've been developing here in these documents. They also give us a chance, the various documents and announcements will come, give us a chance to see if we're being heard and change our influencing strategy if we're not. There are lots of other organisations seeking to influence. I'm in one group for neighbourhood health and children and young people. There must be 70 organisations in it. So there is really a chance to work together and build coalitions. And finally, reflecting on the policy landscape, it's a reminder that to those of us who are working with government, with NHS England, with local authorities and ICBs, that those organisations are really doing their best under extreme pressure. And thanks to those of you in the room or online that are in those roles. So in addition to us being critical friends and influencing around our key asks, I think we'll increasingly have a role to help join up policy initiatives where people have moved on and also provide continuity during this period of change. Thank you.
Does anyone have any questions?
Yeah, does anybody have any questions online? Or put questions in the chat and I can pick them up later.
We
I
have
know Dan.
Q&A at the end
Yeah,
as well.
great.
So anyone can come.
Over to Lou.
I've animated my slides, which means I might be saying next a lot. So go and start with your keyboard instead. Okay.
There was a clicker on the table.
Yeah. Oh, I just go by the sit right down.
I hope the
That'd
animation
be even better. I think they will. Let me check. Yeah. Alright. I'm just gonna get a timeout so I don't overrun that a bit. So, hi everyone, lovely to be here with you all. My name's Lou and I'm a youth social prescriber based in the Social Biobehavioural Research Group at UCL. As a social prescriber, I've worked with children and young people aged between 8 and 18, and I'm involved in various research projects, developing, implementing and evaluating new youth social prescribing pathways, which I know you're going to hear about more later from the research perspective. What I'm going to be talking about is my experiences of youth social prescribing in practice, starting with service delivery, sort of discussion of young people's priorities, and ending with some reflections and recommendations, and then time for questions. So, the social prescribing journey for children and young people, as I'm sure you're all aware, much like with adults, generally begins with an initial referral, typically but not always from a health contact like a GP onto a social prescriber or a link worker. The link worker meets with young person individually to understand their unique interests, values and priorities, and may then refer them on to one or several activities, groups or organisations. But this second step contains a whole universe of things. So I work within a flexible 6-session model. This means that young people can meet with me for up to 6 sessions at a time and a place that works for them. This little graphic is how I explain social prescribing sessions to young people when we first meet. But sessions could be in a cafe or an ice cream parlour at school, their local library or favourite park, weather permitting. Their parent might accompany them to the first session or every session, or the young person might prefer to engage more independently. Sessions can be weekly or more spaced out, even online or over the phone if meeting in person feels too challenging for whatever reason. A session could be 20 minutes of goal setting interspersed with several games of Uno, all of which I lose, or a 2-hour trip to a music studio to try playing a drum kit for the first time. Just have some nice pictures. Online, activities, games, football club. I think one of the most important things that I try to establish in my first session with a young person is this is your time. I'm there to listen to each young person, and if I can, help them figure out how to spend more time doing what they enjoy. If they want to finish a session early or stop engaging, that's okay. It's their time to use as they see fit. When presented in this kind of graphic, social prescribing looks like a straightforward enough process, but as I'm sure you can imagine, it is rarely this simple. It's really anything but linear. Every young person is a world unto themselves, with a distinct constellation of people and opportunities around them. Sometimes after meeting with the young person, you discover that it's actually the service that referred the young person that they need help navigating. And you end up advocating for a higher level of support or adaptations from the school or the service that initially got you involved. And sometimes the outcomes from social prescribing are a lot less concrete than a young person finding and enjoying, say, like a boxing club that they go on to love. Instead, at the end of 6 sessions, you've learned more than you ever thought there was to know about the works of Holly Black, and the young person has returned to writing their detective novel with input from their younger brother, or they've resolved to audition for a major role in the theatre group that they've already been attending, or they've decided to spend more time skating with their friends on the weekend. So, what matters to young people? Everything. Where to begin? There's really no good way to neatly summarise the concerns and priorities of children and young people. One of the things that I'm acutely and constantly aware of as a social prescriber is how many constraints there are in young people's lives. And social prescribing sometimes feels like a kind of antidote because it offers young people real choices on the micro scale, whether to participate, how long sessions should be, where they'd like to meet, but also whether they actually think chess club is a good way to spend their Saturday afternoons, or if their extra 15 minutes on the bus makes a difference to whether they want to try the alternative football team with a coach that has experience working with young people with learning disabilities like theirs. I have a loose framework that I use to shape initial sessions, which is really, it goes like something fun, followed by something creative, followed by something reflective. But in practice, I'm always being led by the young person's specific interests, so that young mind's mood battery becomes a bowl of soup that we're filling up, or the hot air balloon is actually a zeppelin we're filling with their favourite anime characters. But what I think I see young people respond to is the lack of assumption or expectation in social prescribing. So the shared understanding that unless they feel bought in and ready, then we're missing the essential ingredient, which is their enthusiasm. This quote is from one of the young people who were engaged in social prescribing and then took part in a qualitative interview subsequently talking about their social prescriber. They said, he was asking stuff about you, trying to get you out of that bubble you have, but not being too invasive, to say this is like your safe space, you can open up. I really like this quote. I think it highlights how social prescribing's emphasis on activities, hobbies and interests facilitates the creation of real rapport and understanding, which then permits honest discussion of challenges that a young person might be facing and empowers young people to participate in creative problem solving to overcome barriers. It's the difference between a young person telling you that they don't want to do anything after school because they're too tired, and then talking more openly about their caring responsibilities with a younger sibling and what aspects of school they find really draining, which then leads you on to different kinds of conversations about what might energize them. So I think these 2 points are really important. So establishing relational trust and safety and enabling autonomy and agency. They're 2 social prescribing mechanisms of action developed by my colleague Emmeline Han from qualitative interviews. I think they sit at the heart of social prescribing and really go hand in hand. There's lots of factors that facilitate sort of rapport building, not least having social prescribers from similar backgrounds or with shared lived experience. But I also think fundamentally staying connected to a youth-led, choice-based framework is what allows me and other social prescribers to meet young people where they're at and identify activities that would really work for them. So, finally, challenges and recommendations. So if we measure social prescribing success principally as increasing the number of young people engaging with activities in their area, social prescribing can only ever be as good as the local youth offer. And I do think that this is a reductive way of understanding social prescribing. There are so many outcomes and behavioural changes that might stem from social prescribing that won't be directly reflected in the club membership numbers. However, it's true that the availability, accessibility, cost, specificity, and frequency of youth activities really determines what you're able to offer as a social prescriber. And then this gets more complex if the young person has additional support and access needs, is a young carer, or has other family circumstances that might mean they're looking for an activity that doesn't yet exist, or not at a low enough cost, or not with sufficient adjustments. Our per capita enabling grant helps me contend with some of the obvious barriers to access, like the young person needing to rent a squash racket or pay to access the youth centre, and I'm constantly brokering reduced fees or bursary spots where possible. But the most useful thing I found is building strong partnerships with local youth workers and commissioners, because we're truly never alone in trying to address gaps in provision and funding. And finally, whenever I'm feeling really frustrated about the fact I can't find any affordable rollerblading lessons in South London and fretting about the state of the world, I just try to remind myself that young people are the experts, and I'm here to facilitate their decision making and make sure that they have the support and information to try new things. That's me done. Any questions? Or?
So we can do a couple of questions.
Can I ask a question?
Yes.
You'll probably have to repeat it.
Yeah.
Hi there, Emilios Romaniatis. Hi, really good to hear your talk. I was just wondering, do you have any kind of protected space that you can use if the conversation needs to go more private? Is there somewhere that you've got that's allocated that's yours?
Thanks. So the question was, is there any protected space for sort of confidential conversations with young people? This is something that we talk a lot about within my social prescribing team and also at sort of larger community of practice meetings. I think in my experience it really varies where the social prescriber is based. So if you're embedded in a social prescribing organisation, a youth centre, CAMS, a school, quite often you can use their facilities to meet confidentiality. So confidentially, so currently I'm working with schools, and schools will allow me to use meeting rooms, which we sort of often start with to build rapport and safety and comfort for the young person before we go further afield. But yeah, I think that can definitely be a challenge, especially if you're based, say, in secondary mental health services, and you only have access to spaces that feel really clinical. And I think often, I think you hear similar stuff from social prescribers data with GPs, is that they want somewhere that isn't a clinical setting to meet with young people. And I think that's when having colleagues at local youth centres or sort of more spaces that you can access. I also really like a children's library. They're often really quiet and really fun.
Yeah, library.
But yeah.
I've got a question. Yeah, firstly, just to say congratulations on your presentation, because I think you've described social prescribing in probably one of the most articulate and effective ways that I've ever heard, and really got across the complexities and subtleties. So I suppose my question is, to what extent do you see colleagues in the wider sector, be they schools or GP practices, how much do they understand what you do, and how big is the gap between their assumptions or perceptions?
I was looking through the French version of this, and I was very affirmed to see lots of quotes from link workers from the round table sort of mirroring. There's a lot of explaining and re-explaining social prescribing, and one of the reasons I really wanted to emphasise the distinction between like an activity referral, young person starts club, versus all of the other things that social prescribing can do in a young person's life is because I'm having that conversation with parents and guardians and teachers a lot. But I think I think one of the things that I'm often pushing back against, because I'm working with a younger age group at the minute, 8 to 12-year-olds, is quite often parents want something to happen with the young person's motivation and confidence that I cannot promise is going to happen. And so I end up having lots of conversations that are about like foregrounding the young person's choice and autonomy, and this idea that that the sessions are to explore their interests and priorities, and just trying to hold a protective space around the young person to do that. But yeah, I think that's the big question I run into, and as I present on it and I stumble over the word social prescribing repeatedly, and then I'm talking to an 8-year-old who's like, I don't understand what this title is. I'm sympathetic to or accepting of the fact that that's probably something that we're going to have to keep doing and talking about, but that it's so flexible that there's lots of scope to kind of explore what people want to have happen, and the fact that there is this big gap around sort of social connection and belonging and agency in lots of young people's lives that social prescribing can address. I don't know, I feel like that was a rambling.
Yeah, that was brilliant.
Thank you, that's absolutely brilliant. And of course, lots of parallels with adult social prescribing as well, actually. I was really thinking about this, like, adults get referred to social prescribing quite often because there's something quite problematic that's going on in their life. With children and young people, of course, they're going through a developmental process. Children and young people have got lots of questions. Society is very complex. Social media and all that sort of thing, very damaging. I was just thinking, at the sort of stage that children and young people are going through, one could almost probably think that almost every child or every young person would benefit from social prescribing, in a sense of a coach, a mentor, somebody to talk to, somebody to share thoughts with. And I was just wondering what your reflections on that were, really. Do you see young people, because they're referred to, particularly because of some sort of problem going on, something that's been identified, or would you advocate for social prescribing for any young person or any child who said they thought they wanted it?
Oh, sorry. Do you mind introducing yourself?
Sorry, Dan Hopewell from Bromley by Bow Centre.
Great.
So I'm currently working on the ENACT project, which is, so I'm offering social prescribing to young people kind of indicated for loneliness and low community connection. So it's a really specific pathway. But I love the idea of there being lots of sort of open access, self-referral pathways for young people, and feel like that could potentially be really beneficial. Obviously, I'm biased being based within a research group that's really trying to look at for whom and in what context does social prescribing work best. And I do think that that's one of the big research questions. But I notice in sessions with young people that sometimes there's some level of sort of like social skills coaching that is really beneficial, just even questions and conversations about how do you spend time with your friends outside of school and what do you like doing with them, which depending on your family context and your neighbourhood context is more challenging for some young people than others. And if you combine sort of learning difficulties or like family circumstances that introduce additional challenge, I think it's really useful to have an attentive adult who's willing to like talk through the intricacies of that. Yeah, I'm curious about young people's ability to sort of like identify themselves as being someone who might benefit from a service like that, and then needing to be really clear messaging about what social prescribing can offer for there to be some kind of independent uptake. But yeah, I think it's a really interesting question, to which I don't have any definitive answers.
Just to feed in some of the comments that have been coming through online as well, we've had some interesting discussion. Agreement definitely with your point around availability of community activities and social prescribing not being much without kind of funding for the voluntary and community sector. Also people saying that young people might need quite a lot of support in some cases before accessing those kind of activities. People talking about different terminology, so social prescribing might not describe everything that's happening. There might be community connectors or navigators or things labelled differently. And And one specific question for you, Lou, is there a kind of call or an interest in group-based social prescribing, or is it mainly one-to-one that you've been offering or that people have been interested in?
So I do think one-to-one sessions are the sort of like cornerstone of social prescribing, because I think it allows you to do all of the highly individuated, kind of personalised stuff in sessions. Although I think one of the things that sort of, if there was like more funding and capacity across the system, I'm curious about if, so you're working in an area and there's a number of young people who are interested in doing a kind of activity that isn't offered locally, the scope to kind of self-organise that and offer a kind of extension of social prescribing as a group activity. But I think the reality is there isn't enough funding or sort of workforce capacity to be doing that kind of thing at the minute. That's kind of my pie in the sky. But the thing that I'm really aware of is particularly working with younger, like with younger children in the sort of primary school range, is that what we're doing as youth social prescribing looks quite a lot like family system social prescribing also, because there's so much sort of coordination with parents and guardians. And so it feels like the scope is wider than just the individual young person by kind of nature of the process. I don't know if that's on.
I'm XazQ, I'm part of the Social Prescribing Youth Network. So linking from that final point you made, how much parental involvement do you see in this younger age group? And does it ever affect how you offer the service, particularly if part of the issue is due to home circumstance?
Yeah, that's an amazing question. I try really hard to make sure that parental sort of expectations are not shaping sort of the sort of curiosity and attention that I'm approaching sessions with the young people with. But I talk a lot with young people about when we're sort of identifying things they might be interested in and challenges and barriers. Like, how can I feed this back to your parent? How would you like me to talk about it? Is there anything that you're worried about discussing? So trying to build the young person's sort of understanding of their own family system into how I'm doing information sharing. So for any young person under 16, their parents are really involved in scheduling sessions and sort of permission and consent for everything that we do in social prescribing. But trying to make sure that the young person still feels at the forefront of how that's happening, and so that there aren't a bunch of professionals or adults sort of behind them figuring out what they ought to do, but instead they're deciding and letting the rest of their team know because they're the boss. But yeah, does that sort of answer?
Yes, thank you.
Thank you very much. So I am giving the flash talk on research for the session today. And I think it's really important to really use this to acknowledge that there are a number of myths about social prescribing that we need to debunk if we're actually going to have meaningful discussions about how the service is working and how it can move forwards. One of the big myths is around who and how many people social prescribing is actually reaching. When the programme was first launched nationally in 2019, the initial goal that was written was for 900,000 people to receive referrals within the first 4 years of the programme. But actually, last year, for the first time, we analysed GP records, so administrative records, looking at how many people had actually received social prescribing in that 4 years. And we actually found there had been 9.5 million GP consultations, of which 5.5 million had led to referrals. This is 6 times more people receiving social prescribing referrals than had been the original goal. And this is a really important myth to bust, because it actually means that the funding that was put into social prescribing in those first 4 years actually enabled it to be a much larger and higher reach service than had actually initially been anticipated. And far from being a niche thing within the health service, it's actually a major programme that's being delivered. Another sort of myth and concern was that social prescribing wouldn't reach the people most in need of the service. Perhaps it would reach certain demographics disproportionately more than others, maybe not reach those who are from the most deprived backgrounds. But actually, as you can see in this slide, in terms of the gender balance, we can actually see that there was actually a reasonable balance across people who've been receiving the service in the first few years of it. We're actually seeing an ethnicity balance which is better than we have in the UK at the general population level, which suggests that slightly more people from minority ethnic backgrounds receiving it. we're finding that young people are actually receiving it more year on year, and actually year on year we can see that people from the more deprived backgrounds are the ones who are reaching it the most. And crucially, this is just what we see from the GP referrals when we actually look at data that's considered non-medical referrals, which is around, we think about 20% of the social prescribing referrals made, so from schools or from social services or community and voluntary organisations. We actually find that it is disproportionately more reaching people from the most deprived backgrounds. And this is really important to acknowledge, because it suggests that this programme is actually self-targeting increasingly towards the groups who need it the most. But of course, this is looking at all age social prescribing, and as we heard earlier, there has been another myth around, is it actually young people who are receiving this? And as we heard earlier, it is actually already a service that is reaching children and young people. We've just completed analyses of Elemental, which is the biggest cloud-based industry platform looking at social prescribing referrals across medical and non-medical referrals in the UK. And this is specifically looking at referrals to people under the age of 25. And where, as you can see here, it's the people in the most deprived areas amongst young people who've been receiving those referrals in the last few years. We're actually seeing that year on year, there are actually more non-medical referrals. But 2019 is a bit of a mess because that was before the GP service was officially rolling out, which means that we were seeing more non-medical proportionately, but is actually increasingly going through the non-medical routes. And across the age groups, we can see actually that non-medical referral routes are particularly important for primary age children. Interestingly though, we are seeing that it is the younger age groups that are not receiving it quite as much as the older children, so there is still work that needs to be done around targeting there. And we're also finding that year on year, again, these younger age groups are accessing it less. It's particularly going towards the older young people in this age band, so there's definitely work to be done. But interestingly, we're seeing that the reasons for referrals are quite diverse, mental health coming up as the most common one, but a number of other reasons also being cited for why young people are receiving this. And this is work that is about to be pre-printed in the next week or so, which is the first time we've had this rich picture about youth social prescribing at a national level. One of the things that's been a big question, of course, is what impact do we see from social prescribing? We've had so many incredibly rich case studies and local evaluations, and also increasingly trials that have been conducted looking at social prescribing in different populations. But there's sometimes been this need for sort of conversations around what's the national picture on this. So again, using administrative data, we've been able to identify that there are pretty reliable 20% increases in well-being that we see from before people are referred to social prescribing to sort of 3-month follow-up afterwards. And this is what we found from adult social prescribing data, but actually we've just completed analyses looking at youth and found that they have almost the identical 20% increase. So this is really exciting because it's exactly what had been shown from the local evaluations, but when we're extrapolating up and looking at the national data, we're seeing very much the same kind of picture, which is very reassuring. Notably, we're actually finding that these increases in young people are particularly strong for those who have probable depression at baseline, suggesting that those young people who potentially need the service the most are the ones who see that greatest improvements. And we've just started doing the first health economic analyses at this national, using the national data, and finding that just for these well-being improvements alone, the return on investment for well-being is £9 to every pound that goes in, which is a really reassuring picture and actually builds into a lot of the same kinds of figures that have been coming out of similar large returns on investment for well-being from things that have come out like the green social prescribing or from more of the local level evaluations as well. But then a big question, of course, is about whether we can then target social prescribing specifically to some of these groups who could potentially need it the most, but also who might be in some of the more complex pathways. So thinking about child and adolescent mental health services is really key here, given that this is a population of young people who are often put on very long waiting lists for clinical care, but where there's a really nice opportunity to consider whether social prescribing can have a role to play whilst they're waiting. We've been leading a trial from UCL over the last few years, which has been funded by the Prudence Trust, called Inspire, Wellbeing While Waiting, which has been trying to design and develop how we can implement social prescribing in a way that meets the needs of the health service, is safe, and really considering the vulnerabilities and needs of young people, and also trying to support their psychological experiences. This trial has involved 11 CAMS sites across England, and we published quite a bit in terms of manuals of how other CAMS can take the information and build their own pathways. We now actually have the full data back from the trial, and we're shortly going to be publishing the paper on this. What we've actually found is that social prescribing seems to be particularly well targeted in this population in terms of supporting their strengths development. So we're finding, for example, increases in pro-social behaviours, increases in resilience for those who are offered social prescribing relative to control groups, as well as reductions in behavioural difficulties and conduct difficulties. This is really interesting because actually we weren't seeing the reductions so much in things like anxiety and depression, but we're seeing this in this strengths-based approach, which is exactly how we might sort of theorise that social prescribing works, but it also is really important on waiting lists. Because if we're starting to build up all of these skills amongst young people prior to them getting their psychological interventions, that can help to make them more treatment ready, meaning they're in a better position to then receive brief psychological interventions, for example, when they get to the end of that waiting list. But we've also been identifying that this is a really complex setting to work in, and therefore it's crucial to get it right. It's not that we can simply imagine it's a simple process where you put a link worker in and hope it's going to work. And what's been really strong about having so many sites involved in this project is we've been able to identify what are the ingredients that are necessary to make this a really effective service, and also how is it that this service helps to lead to these improvements. And particularly we find that social prescribing can be a way of establishing relational trust and safety for young people, building their and enabling their autonomy and agency, and that this can then support with secondary things like supporting emotion regulation, developing healthy coping strategies, improving family communication and dynamics, increasing their social connection and participation, and promoting behavioural activation and motivation. But of course, this then depends on contextual factors being designed carefully to support this. So making sure, for example, that there's strong caregiver involvement, that we're accounting for things like young people's past experiences of services, which could easily get in the way of social prescriptions if we're not talking about them. We're considering very much the complexity and severity of their needs, and also the availability and accessibility of local resources. And really this builds on everything that Lou was talking about earlier in terms of how we can take the learning from the individual link workers and build this up into a portfolio of knowledge that can enable social prescribing pathways to be really smoothly and effectively integrated into these very complex settings. The good news though is we're showing that it is possible and that it can have impact, and we've got a number of other studies that are underway in other settings where we feel there's a really clear need for social prescribing. One of these, ENACT, is considering taking this more into prevention, so thinking about how social prescribing can be used within schools for young people who are showing signs of loneliness as a way of helping to build that strengths-based approach before potentially the loneliness becomes a risk factor for things like mental health problems. And this is a study that's now into the second stage of the trial with 30 schools. And then the other one is called CASPER, and this is considering the opposite end of CAMS, so thinking when young people have had their brief psychological interventions, instead of them simply being left to carry on life so-called as normal afterwards, actually giving them a step-down approach that says, well, can we now use social prescribing to help you integrate with your community, to find ways of putting the things you've learnt in your psychological interventions into practice in your own lives and trying to maintain some of the benefits that might have been achieved through that treatment. And this is a study that's also underway, so both ENACT and CASPER will be reporting full results next year, which will be a chance for us then to have the same kind of learnings about how we can be really targeting social prescribing to where we feel it's got the greatest impact for young people. So I'm happy to take any questions, but I hope that's a kind of overview of what's happening within the research landscape on this and how we're hoping to develop both better monitoring of who social prescribing is reaching and how we can optimise that, as well as more sophisticated pathways of embedding it in places where we know there's the greatest need and the potential for greatest impact.
Thanks, Daisy. So we had one question come in online from someone who is working for an active partnership in Plymouth, and they are providing targeted social prescribing into physical activity in the community. They've got referrals coming in, but they don't believe that the activity and the outcomes from this work are currently feeding into national social prescribing data sets. Could you explain how social prescribing data is captured nationally and what we need to do to ensure that the work happening in Plymouth is included both in the national and the local picture more widely?
Great question.
Excellent question. At UCL, because we have the partnership with NASP as the National Centre for Social Prescribing Data Analysis, a big part of what we're doing is considering how we can actually be monitoring and capturing outcomes. One of the simple things that can happen, particularly within GPs in primary care, is that social prescribing can be captured in clinical codes, such as SNOMED codes that go into patient records. And this can enable the kind of tracking of the rates of social prescribing, but this is not without its challenges, partly given the fact there are over 27 different codes that can relate to social prescribing. So we're currently in the midst of a piece where we're actually tracking how much each individual code is being used and whether it's possible to actually streamline this into something that would make a little bit more sense for reporting kind of annual auditing and monitoring. But in terms of outcomes from the social prescribing link worker survey that we've analysed, we do know that there are at least 1 in 4 link workers who never record any kinds of outcomes, which means that we're not getting a full picture of what the outcomes are. Fortunately, our analyses suggest that the outcomes experienced by link workers who don't report are no different from the outcomes of link workers who do report. So they both perceive that social prescribing is having a similar impact, but there's definitely work around how to capture. So some is around things like Elemental or other big data sets like that that actually allow people to input outcomes. Elemental is a particularly good one because we actually have full data access through a partnership with them at UCL, which means that we're able to do a lot of analysis and reporting on outcomes through the anonymous data that we receive from them. And sites have got the option to choose what kind of measures they can use within that, and there are recommendations about things like ONS4, but other outcomes that are sort of most commonly used there. But other than that, it comes down to sites actually recording their own outcomes. And of course, the big challenge then is it might be useful at a local level, but then if it's just captured in Excel spreadsheets that are never being brought together nationally, it means that we can be missing out on some of that. So a large part of what we're trying to think about is how we can strategize a sort of stronger way of being able to capture some of that outcomes work. And I won't talk about it now, but there are some programs underway that are considering how we can bring some of those data sets together.
I'm Laura Barber from the Chimo Trust. I think it's slightly building on that question. When you're talking about the data from the social prescribing, how do you differentiate between what might be determined by the relationship with the link worker or actually by the therapeutic activity that they're referring on to?
This is a question for those online about how we know if it's the activity versus just the therapeutic effect of the link worker, or I guess it can even be things like placebo effects. The truth is, in any kind of psychological intervention, we know it's a combination of all of these things that lead to the outcomes. What we can see from trials is we're able to sometimes disentangle this by having active control groups that allow us to, for example, give people an intervention that's giving them attention or even giving them one-to-one support, but without the same kind of coaching and mentoring and in-depth experiences that we've heard from Lou that young people get with social prescribing. Interestingly, what we see in the trials from that is that it doesn't appear to be purely that these intervention effects aren't purely coming from placebo or therapeutic alliance that you would expect with the leader. That's part of the percentage of the association, but actually a large part still comes down from the active intervention itself. But I do think it's also important to acknowledge that, as with psychological interventions, it is about multiple mechanisms through which they work, so it's not about trying to bring it down to one reason that they're effective. Often it is that combination of all of those different processes that Lou described so eloquently earlier that young people get when they go into social prescribing.
Hi, I'm Eve Allen from Edge Hill University. I've worked in CAM services previously. This work that you're doing is really insightful and thinking about before and after. Have you gained sort of the thoughts around CAMS workers on this work about supporting and getting children to the right place to therapeutic services? Because in my experience, sometimes, you do get those, you're not ready for therapy, and this work that could be happening, could be preparing, and could have a really big input and a great change for young people in accessing therapeutic services. So it would just be great to get sort of that impact on the workforce as well.
We are actually looking at that through the Wellbeing While Waiting Inspire trial. We're actually just about to preprint a paper where we've looked at the experiences of healthcare practitioners and how this actually feeds into the sort of supporting CAMS staff themselves. And interestingly, it's been really positive
responses from them, I think because there's this recognised need that there are these long waiting lists. And interestingly, when we did work looking at the young people who were on those waiting lists, one of the big things that came up is that they and the staff as well were concerned about the fact that there were often deterioration during that waiting list period, and that young people were often, and their families were often trying to seek other support, but not in any kind of guided way. And there's concern about would they be trying to find things on the internet or whatever that actually wouldn't be appropriate. So knowing that there was a sort of midpoint of a social prescribing service that's linked into the CAMS but sort of has a bit of autonomy in that, actually meant that there was a better feeling about safeguarding around this, and also that the safety of the interventions that the link workers would be recommending.
Yeah, I think it's really important for parents as well, isn't it, to have that safety net. And what Lou was talking about, that frustration in the sense of, okay, I'm going to refer to, I don't know, equestrian support, therapeutic services, and then they've got another waiting list. And I think that's something else that we need to capture in the sense of waiting list for CAMS, but then waiting list for social prescribing as well, which is important. Thank you.
Wonderful. I'm going to pass that to our organisers.
It's me now.
Yeah.
So it's my turn, along with Dawn, who I'll pass over to. So I've got 5 minutes. I might try and cut it down slightly to make sure that we're not running over time. So I think most of you know me. For those that don't, I'm Dan. Can you hear me okay? And I'm director of the Social Prescribing Youth Network, and I'm really happy to be here today to launch kind of 2 resources that we hope will kind of further the field of youth social prescribing. One being the best practice guidelines that we've got in front of you, and the other, which Dawn will touch on a bit more, is the youth social prescribing training. Having worked in this field for a few years now, both in SPYN context but also as a researcher, one thing that's kind of come up time and time again when talking to people on the ground, researchers, policymakers, is that there's really good practice going on. However, this often isn't captured anywhere, and also it's very, very patchy. And we hear frequently about there needing to be guidelines and training, because otherwise people are just working in these silos on their own, trying to adopt or kind of change adult guidelines to suit young people, but not really knowing if what they're doing is correct or if it's working. And often, in the context of youth social prescribing specifically, these people are often the only person working in that setting, so they've got no one to bounce these ideas off. So, since taking over SPYN, one of the tasks that we've been doing for the last year is trying to develop these best practice guidelines, which you've got in front of you today. So, as part of this, what we've done is, for the last 6 to 8 months, we've been holding roundtables with policymakers, commissioners, young people, link workers, researchers and academics, and third sector organisations. And through all of these roundtables, the one thing that we've tried to establish is what does good social prescribing look like in the context of young people. As part of this, we have kind of gained all these insights and tried to distill it into the Youth Social Prescribing Toolkit guidelines, which were developed by Liza and Dawn. And this kind of fits into 5 overarching categories, which are leadership, policy, workforce, impact, and digital. Is that correct? Yeah. However, across these, there's kind of some key cutting themes that, oh God, I haven't pushed any of the
That's
slides
fine, I'll do it.
forward. Next one. There's kind of 5 key cutting themes that we think need a fundamental shift in systems change in order to make youth social prescribing and best practice possible. The first is around named leadership, and Rachel talked on this a little bit. However, what we're hearing repeatedly is that there's nobody taking responsibility for youth social prescribing, and various policymakers and commissioners have defined it as a rudderless ship. So in order to be able to really push forward the youth social prescribing agenda, we really need named clinical leads at a system level and an ICB at place level as well. The second is that youth voice should be mission critical and not optional. In some areas, we've heard excellent examples of where youth have been involved throughout the entire process, including the design and delivery of the social prescribing services, and the interviewing of link workers who were then put on their caseloads. However, in other places, this was very much done tokenistically, or in some instances, not at all. And if we really want to be developing services for young people, they need to be at the heart of these decisions, otherwise they just won't be effective. Third is the workforce, and this needs to be protected. Rachel again touched on this a little bit. However, what we're hearing from link workers on the ground is that they're increasingly seeing more and more complex cases. And actually, when we then take that in the context of youth social prescribing, often these young people have taken a while to get to this crisis point. It's not that they're accessing things straight away like older adults may do, so the complexity is already embedded there. But then on top of that, you've got to navigate these multiple stakeholders, be that parents and schools, adding additional complexity there as well. In order to really protect the workforce, what we're calling for is adequate clinical supervision, and this is very patchy at best at the moment. On top of that, we need clear escalation processes for individuals to refer on when cases become kind of more mission critical, and also protected time for things such as workforce development and community asset mapping. Fourth is kind of matched funding, which Rachel already touched on, but without adequate BCSE funding and it following the young person through, we're relying on inequity and goodwill, and this means that trust is broken down and the system is broken. Last, from a research perspective, we need to be better at capturing social prescribing as a complex intervention. At the moment, we're currently quite frequently only catching referrals in and referrals out, and this is at best quite a patchy measure. What we really want to be doing is looking at the quality of the social prescribing counter, but also the mechanisms that kind of make it up.
Next slide, please.
So just to kind of summarise a bit more, youth social prescribing can act as connectors, and we should be doing this through a no wrong door infrastructure, and this, in doing so, will link primary care, secondary care, education, early help and community assets. But in order to do this, we need leadership that is named, funding that is multi-year, a workforce that's protected, youth voice embedded, and data systems that are aligned. What we're hoping for these guidelines, they set out what commissioners should specify, what leaders should embed, what BCSE partners should expect, what researchers should measure, and what young people expect. We know that youth social prescribing is currently happening. We just need to make sure that it's not being done out of goodwill in order to make the system infrastructure work. Thank you. And now I will hand over to Dawn to talk about the training.
When Dan said it's not going to be a long session, what I heard is Dawn don't talk too much. So just a very brief introduction to a couple of things that might be of interest to people. So we've got the best practice guidelines that are obviously being launched today. The other thing that we're really keen to promote is some essentials training that's been developed by NASP and alongside UCL and the Social Prescribing Youth Network. So Dan and I have been working with colleagues at NASP. Specifically, we should say thank you to Hannah, who's done all the technical build behind the e-learning that we're also launching today. So the e-learning, it's called the Essentials at the minute. I don't know if we've got that's a working title or it's going to be developed into something more shiny. But it's about 40-45 minutes of e-learning that's self-directed, that is there to try and showcase the best bits of what we know to be working with CYP social prescribing, and to help people go from knowing very little, maybe having an interest, someone's mentioned it to them, to going and learning a little bit more, and hopefully getting them excited to delve into some of the more technical things like the best practice guidelines, like the toolkit that are already available. We're really keen to keep people focused through maybe just one portal. If you are talking to people, if people are interested, we're trying to direct everyone through the Social Prescribing Youth Network because people are time poor. If people are interested in social prescribing for children and young people, we want them to know where to go to get the right information as quickly and easily as possible. So we're trying to do that through the repository that UCL are holding and developing. So we're trying to signpost people there. So we've got the new essentials training, which is really to take people from thinking, what's it about, to lose point. Social prescribing, you know, we've spent years, haven't we, sort of going over what it is, what it isn't. Young people do not call it social prescribing. We've got the projects up and down the country that have developed their own names for their projects that mean that it's identifiable locally for young people. So I definitely agree with that point. The other thing just to mention that is available as a resource that's relatively new is that, again, working with the National Academy, we developed a flip book around social prescribing that looks at where social prescribing fits in different systems at place. And the idea when we created the flip book was really to try and say to people, because it isn't like the adult model, it doesn't just sit in one place and isn't just accessed through one route. What we're talking about, and we've alluded to it in a number of conversations, is the opportunity for the wider workforce to all take a social prescribing approach and to have those protected conversations with young people. And to try and demonstrate that, and it was my colleague Tracy Lyons who's moved on from NASP now, but really spearheaded this flip book. And it's about what if we flooded this place with the social prescribing approach, and everyone took the same approach, and we have all the different systems linking into social prescribing in different ways. So again, if you're interested, you can go in and just have a look at the different case studies and see where it's working really well. So just promoting what resources are available really, and hoping that people can engage and take it back to people who might be able to make decisions locally. So hopefully that's of use to everyone.
And now I'm going to hand over to XazQ. XazQ is one of our youth advisors who has sat on the SPYN advisory board for the last year and has helped develop the best practice guidelines.
Thank you. So yeah, I'm XazQ, I'm part of the Social Prescribing Youth Network. So a bit about what we do in the network is we've done things such as hear back from the roundtable inputs, and then we comment on what's been said from the different groups. So you can see this summaries around the room. So we see these and then we talk about it, and we talk about how we talk about the formatting as well of the information, and we give from a young person's perspective what we think is the most important from the different. So, for example, from the link workers one, what we think is the most vital to focus on from a young person's perspective. And most recently, we did a creative and accessible summary of the best practice guidelines, which we're showing at the start of the symposium. And why I got involved is because I've had an experience with a more informal sort of social prescribing, in that I was prescribed to a community physiotherapist, and then he said in a way he almost acted like a link worker should. He sat with me, he said, okay, what kind of activities do you already do? These are the things you need to do to improve your condition. And then we talked about potential things I could start. So, for example, swimming or a Pilates club nearby. And then he did things like suggest a running club, and I hate running. So, so I had that kind of experience with that individualised approach, as Lou was saying. And that's eventually why I got involved with this. I have so in terms of what I think about youth social prescribing, I think it would be a very good alternative to potentially dangerous medications for people to take. Because I've had a few friends who haven't gone through social prescribing but were given antidepressants or other medications to help with particularly mental health. And they've all said, oh yeah, the doctors tell you that you get worse before you get better. And for some people that could be dangerous or unsafe. And I think social prescribing could be a very good alternative. But it has to be more accessible than the current mental health services. I can't remember who mentioned it, but someone mentioned the insanely long waiting lists for things like CAMHS and mental health services currently. And even school counsellors. So my school counsellor comes in 1 day a week, and so everyone in the school, there's around 1,500 people in the school. Everyone who needs to be seen can only see 1 day a week. I know other schools might have more of a provision, but again, these kind of services aren't accessible regularly. And I think for social prescribing to work, particularly for children and young people, it has to be more accessible. You need to be, even if it's once every 2 weeks, as Lou was saying, that's still better than waiting 6 months without hearing anything and then seeing someone and they're like, okay, your case is emergent. Or being in a school counsellor, seeing them once and then not seeing them for 2 months because you've had a school holiday, and then everyone's been seen. And again, I think waiting lists as well should stay short for social prescribing if possible. Of course, that depends on funding. And I think my last point as an improvement would be awareness needs to be raised in schools about this. I talked to my friends a bit about this because they were like, why are you taking the day off school? So I said, oh, it's for this. And nobody knew what it was. And I think that's definitely a downside to this because it's such a great initiative. It's so helpful to so many people, as we've seen from the statistics as well. I think having that awareness in schools, both from the children and the general population of teachers, and not just Senko or the safeguarding team. Because if people are aware of it, then people will ask for it. They'll go to their GP, say, I don't want to be on this medication. I don't want to wait 6 months for therapy. I would like to see a link worker if possible. And that might help people more than the alternatives. Yeah, that's why.
Good afternoon, everyone. My name is Dr. Polley MBE, and I'm here to kind of let's start to think about the future direction for children and young people's social prescribing. So on the Menti, there was a question on top 5 priorities. So let's have a quick look. So I said to Dan, the top priority would be, Dan, what did I say a couple of weeks ago?
Funding.
Funding. So the top priority is strong BCSE partnerships now. So I was wrong. So where's it? No, next one. Hold on. Funding cycles. In everything I've done, funding has been a top priority for social prescribing for the last 15 years. So it's almost taken as said. What is really good to see is the second point, youth voice embedded in governance and evaluation. A lot of the work that I do when I do evaluation is actually asking people what matters to them. I have an outcome measure that asks people. And you can never assume what is important to a person because you always bring your own unconscious biases with you. So I think having the youth voice is absolutely essential to make sure it works for the people that need to use the service. And we've just heard from Saskia all about that, and that was absolutely brilliant. And of course the VCSE capacity funded. So this is kind of like, we kind of know this has been said, so let's just move away from this, we can get rid of this. I'm going to ask you 3 questions. Because at the moment things are pretty dire with the NHS. Nobody knows who's going to be in a job anywhere. We don't know what the boundaries are, we don't know what the policies are, we don't know if social prescribing is a term that's going to continue to be used. What else don't we know? Who's got a job at the end of March? All sorts of things. And with this comes opportunities. So it's really difficult at the moment, but it brings opportunities. So to move forward, who can you influence? And if you're online, then just put in the chat. Who do you think you can be influencing?
So XazQ's just talked about actually we need all the teachers to know about social prescribing. So actually, do we need this on the education curriculum? So who do you know in the Department of Education? Who do you know in your local government? Who do you know that's got pots of money? Who can you influence? Okay. The second question is, what can you piggyback on? So when we brought social prescribing in for the first time, actually it was on the back of a loneliness strategy because Joe Cox got murdered, who's an MP, so suddenly all the MPs were like, gosh, we've got to do something. This strategy was created, it was a cross-government strategy. Can I just say it's cross-government buy-in? It wasn't a Tory policy, it was a cross-government buy-in. And it was a way to bring social prescribing in, and even the term was piggybacking to help medical professionals understand there's more than medicine. So what can you piggyback on? What are the local policies? There's never going to be one policy that says social prescribing, yes, let's do it. It comes in on every other policy that's there. So what can you do to piggyback on a policy? And who can you collaborate with? So social prescribing is about collaboration, it's not about competition. I feel like I should say that because I started 10 years ago saying collaboration, not competition, so I feel like we should get that in. Who can we create with to create those ecosystems in the community? So we've talked about teachers, we've talked about youth workers, we've talked about other professionals, so that it's not just, it's this or it's that. So, I'm going to give people online like 1 or 2 more minutes to put a comment in. So 3 questions have gone out to the room. They're looking scared because I might pick on people now to answer. But everyone's been sat here. So stick your hand up if you think you know who you could influence, what you could piggyback on, or who you can collaborate with. Right, I'm going to give you 1 comment, Lisa.
Okay, so in terms of influence, I think the people that we should be influencing is young people themselves, because I think if you want to have a social movement for change, then young people are the way to go.
Marvellous, thank you. Right, Edgekill, can't remember the name, but I just remember Edgekill.
Hi. Well, we've piggybacked a little bit on local authority. I was talking to Dawn that we've got an area that really doesn't like people going in unless they've got trusted relationships. So we've built trusted relationships with community members who then will instigate the CYP social prescribers going in. So it's just about who you build those relationships with.
Thank you, and arguably local authority might be a safer bet at the moment than trying to find the NHS leads until they reorganise local government.
That's me. I come from a local authority from Coventry, so we work with the Vanguard team, and then we work within the Educare service. So referrals come from social workers, and then we do case formulations, and then we do the social prescribing from that. So that's how we do it, and that's on the back of trauma informed. So we work in a trauma informed way, and then we get funding through our family and valued services, which is in the Coventry City Council. That's how we do it.
Brilliant. So that almost addressed all 3 questions. So 10 brownie points to you. Rachel, I'm coming over to you. What have we got online that's coming in?
Sure. So we have Claire Faulkner from Chichester District Council saying that she has piggybacked on adult social prescribing service to gain momentum and get referrals. We've had Philippa, who said about the local authority, health and VSC strategic leads. All of them is people work, and they need to get out and talk to people they're deciding on services for. Place-based convening at a neighbourhood level, collaborating with all key stakeholders. It's in health policy, youth strategy, schools, IND, youth providers, council and commissioners, parents and young people, school parent coffee mornings. We also had someone, Amy Davies from Public Health Wales, who said that they are very interested in connecting with colleagues presenting here today. The public system across Wales are committed to strengthening social prescribing opportunities for children and young people with a national offer that meets needs. So that sounds like an opportunity for sure.
Yeah. Brilliant. And Claire Mackenzie, where are you from? Where you said place-based convening. You just mentioned lots of stuff, so maybe Claire, you can just tell me where you're from as well in a minute. So there's lots of ideas of how we can move forwards, but we've got to do it together, because this only works when everybody collaborates with each other, when everybody shares what they're doing proactively. Oh, I've just thought, I might message Daisy and go doing this, or we've got this, or someone publishes a paper and I'll email them and go, I know a service that's doing that you might want to talk to. We have to be really proactive, because the only way this is going to work if we make it work. So what other comments are there in the room? Dan? Oh, hold on, did someone else put a hand up over there? Oh, you've both said stuff before, so I'll both give you a go. Short comments.
Just very briefly, I guess, adult social prescribing is in a very precarious state, we know that. And, but it was sort of national policy. Indeed, actually in 2019, the policy never said 18 upwards, the policy never distinguished, so in theory it should have always been children and upwards. But for some reason, children and young people social prescribing got off onto a different footing, as we know. But in this moment of great precarity for both adult social prescribing and indeed because children and young people's social prescribing never really became sort of nationally adopted, I think there's a sort of interesting question: do we want this dichotomy of adult social prescribing for one side and children and young people's for another? Or do we need to join forces to reassert the need for social prescribing, reassert the evidence and the policy requirement? I mean, the last government said we would get 9,000 adult social prescribing workers by March 2037. The numbers are actually now going down rather than up. I think we need to go onto the front foot and maybe together, children, young people and adults together, and reassert the argument. Yeah.
Thank you, Dan. That's a really interesting point about it was never an adult service. Let me pass over to
Emilios. Hi, thank you. Emilios, representing the Tavistock and Portland in this moment. So we run a social prescribing platform which covers the whole of North London, NCL, called Waiting Room, which started with children and then moved to young people and then it moved to adults and then it moved to professionals as well. And so just in terms of what we can do in terms of collaboration, I'd like to try and link our platform's data with the UCL group so that you've got access to our data, and I'm not sure why that's not happened in the past. Yeah, but let's try and make it happen, guys. Yeah, cool. Wicked.
Thank you very much. Right, I'm just running over here with my phone.
Hi, I'm Jess Tran from Creative Lives, and we represent voluntary community sector groups, and that's come up a lot, hasn't it, in terms of that provision, and I still don't know the answer really, that if there aren't those services to refer people into, choirs, drama groups, music groups are accessible, it's difficult to see how it works. And then I've also got another hat, which is a parent hat, and thinking about just how complex services are to navigate, and it feels like, is there another service that you have to do a referral for, meet another person, have 6-week sessions, get outcomes for? It's really complicated as a parent to navigate. So I know this was a solutions question, but I've just come with 2 questions really. But yeah, Creative Lives really want to work with the people in the room.
Thank you very much. And actually, I think one of the benefits of social prescribing is they can help people navigate all the other systems. So actually, it's the hub when you've got all the other spokes, and I think that's what can really help. Micro-commissioning is a really good model of looking, from local authority, whoever's got a pot of money. The Rotherham Social Prescribing Service looked after all of their link workers, they employed them. When they found there was a need, they micro-commissioned the hall and the money to pay the rent and a bit of training to create that. I mean, Ways to Wellbeing in North West. Newcastle, North East. My geography is rubbish. Often talk about the ukulele shop, because there was one person that played a ukulele, and actually a few, and then a group got together, and then there was a shop selling ukuleles. I mean, that's a whole way that social prescribing works. You laugh, but people got employed, connection, group, outcomes, tick, 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 tick. So I think there is all of that. I imagine I'm going to have to round up in a sec. What I do like having heard is people already offering to collaborate. That took 3 minutes to get collaboration going. Isn't it easy to collaborate? It's much easier than to compete. So for everybody in this room, before you leave, I want you to talk to someone you've not met and think about how you can collaborate with each other. And the people in Wales, I think that sounds brilliant, because Wales have done a very different way of implementing social prescribing. not the haphazard way that it happened in England, but much thoughtful way. So I think there's some really good ideas there. So shall I finish up now? Is that all right? I'll hand back over, but thank you.
So we're going to be wrapping up now. Just a few things. So firstly, thank you to the Southbank Centre, NASP and the Prudence Trust for helping make this event possible. And a special thank you to all the speakers today. So Dawn, Liza, Rachel, Daisy, nearly said myself then, XazQ, Marie. And then actually a big special thank you to Rachel and Nikita. Nikita is part-time, so can't be here today, but actually it's been them putting everything together, including some of the work in the best practice guidelines. This event would not have been possible without them, and thank you so much. So we've got 15 minutes of technical networking now. I don't know what technical networking is, like before the session officially ends, but we've got the room booked for longer, so if people want to stay, feel free to. It's your time to use as you want now.